Broadcasting live from the North Fulton Business RadioX studio, it's time for To Your Health with Dr. Jim Morrow. To Your Health is brought to you by Morrow Family Medicine, an award-winning primary care practice, which brings the care back to healthcare.
Hello, this is Dr. Jim Morrow with Morrow Family Medicine, offices in Cumming and Milton, Georgia. We're here today for another episode of To Your Health, and I think it's going to be a great episode today. We're here in the North Fulton Business RadioX studio on Windward Parkway, here with John Ray. John's running the board and taking tweets and emails, and we'll talk about that in a second. How you doing, John?
I'm doing great. How are you?
Good. You getting over that cold?
I am, thanks to the early office hours from my family care physician.
Great. That's good to know. I'm glad to hear that.
That's how I started coming to your place.
Well, it's one of the best reasons.
Well, absolutely, because I couldn't get into the one I had wanted me to wait 3 days until I died, and then they would see me.
Drives me crazy.
I know, and that's how I got to you.
So at Morrow Family Medicine, we do have a walk-in hour every morning. We open at 7:30, and for the first hour of the day, you don't need an appointment. If you just walk in, we will take care of whatever's going on with you right then and there. We see walk-ins every day, Monday through Friday, in that hour from 7:30 to 8:30 in the Cumming and the Milton office. And that way, there's never a weekday you can't be seen in one of our offices. And we like to say that we're bringing care back to healthcare, and that's one of the ways that we're doing it. So this is our 19th episode of the podcast and radio show, and we're excited to be here again. We do have a couple of ways you can get in touch with us if you want to. You can email us at Dr. Jim, that's Dr. Jim, at toyourhealth.md, or you can tweet us at toyourhealthmd. So that's two ways you can get to us if you have recommendations for a show or suggestions or comments about the show you're listening to at the moment. We try to gather some questions during the show and present those to you and come up with some answers at the end of the show every time. So today we're going to be talking about dementia. Dementia in multiple forms. People think about dementia, they immediately think Alzheimer's, but Alzheimer's is a form of dementia. It's not the only form. And we're lucky today to have with us a neurologist from Cumming, Dr. Peter Futrell. Pete is the neurologist, one of the two, with Lakeside Neurology in Cumming, Georgia. I've known Pete for about 20 years. Pete, how you doing?
I'm great. Glad to be here with you guys today.
I appreciate you doing this for us. So I was
a little inadequate because I don't have walk-in hours from 7:30 to 8:30 every weekday.
But you can start anytime.
Patients, but
you can do that anytime you want to. I bet your people would be tickled to death. But I will say I've been referring people to Pete Futrell for 20 plus years, and getting in to see him when you need somebody to take care of you from a neurologic standpoint has never been a problem. And I do appreciate the care you take of the people in North Georgia. So I started researching dementia a little bit because honestly, it's something that family doctors are probably a little bit weak in. I know I'm a little bit weak in that particular area, and that's why I'm thankful that you're around. But what I read said that during the in the 70s, and people's ages of 71 to 79, 1 in about 20 people will have dementia of some sort. In 80 to 89, 1 in 4, and over 90, 1 in 3. And so with the population aging like it is, this is an obviously increasing problem for everybody out there.
It keeps us busy in the office. That's for sure.
I know it does. So
you refer patients to us all the time, and including for dementia, and of course appreciate that. But sorry to see the patients with it, but of course we try to help. And there's no shortage of them out there, as you're suggesting with those numbers.
So Pete, tell me in your words, what exactly is dementia?
Well, the term dementia just refers to a progressive decline in cognition. So people can have cognitive issues or maybe just isolated memory issues for any number of reasons. But if it's not a progressive thing, so for example, if somebody had a brain injury and they had some cognitive issues from that, that's not dementia. That's a one-time event that happens to the brain. It can affect them. It can be residual through their entire life. But it's not something that necessarily will get worse. Right. Dementia, on the other hand, is progressive. As you said earlier, several different forms. People always equate dementia and Alzheimer's, but that's not always the case. It's usually the case, but not always.
And what are some of the other things that might go on in your body that can make you have dementia?
Well, that's probably a long list. When we see somebody who we at least suspect dementia, we, of course, always start looking for the basic things first. As you know, some of the simple metabolic issues. Thyroid disease is a common one that can cause cognitive issues. If there's some undiagnosed kidney or liver problems, those could at least mimic dementia. Of course, medications can cause some confusion. Sometimes can be hard to discern if it's medication effect or it is dementia. As far as different forms of dementia, so there's the Alzheimer's, which is by far the most common, but things like vascular dementia, which occurs from usually multiple strokes. There's frontal dementia. People with Parkinson's have a form of dementia that's not technically Alzheimer's, but very close to it. So a lot of different things to consider. Right.
So if you suspect that a patient has dementia, other than what you would do in the office, are there other ancillary tests that you do? Do you order CAT scans, MRIs, that kind of thing?
Of course, yeah. And it depends on, as with anything in medicine, it depends on the patient, all the different variables, whether it's age or medications or other medical issues they might be having. Obviously, in the office, we can examine the patient. We can test their cognition. Probably most important actually is having a family member or someone else who can provide history. Obviously, if you have a patient who's having cognitive issues, they're not always the best historians. Sometimes because, of course, they don't remember, and other times they just don't have the insight and they're not aware of even having a problem. So that's what we do in the office is the exam and history, of course. After the office, it's checking lab work, like, for example, the thyroid we talked about. Vitamin B12 deficiency is a common one that can cause cognitive issues. The imaging, almost always either CAT scan or MRI. Kind of depends on the patient's age and what else is going on with them, how we just decide if we choose one or the other. May do a EEG, electroencephalogram, looking at electrical activity in the brain. It's at least possible for some types of seizures to go undiagnosed and to manifest as cognitive issues. So that's always worth screening for. Other than that, one test I use a lot, and I think most neurologists would agree with me, is sending the patient for formal neuropsych or neuropsychological testing, which is a battery of tests. As I tell patients, it's kind of putting your brain through the ringers, a kind of a stress test for your brain, looking at all forms of cognition, whether it's language, memory, concentration. And usually neuropsychologists is pretty good about sort of teasing out what might be causing the cognitive issues, whether it's dementia, mood issues can certainly fool you and look like dementia when, for example, it might just be bad depression. So we use all those things and kind of put them in the pot and mix them up and see what it looks like when we got them all together.
Right. So in the office, I see people every day, seems like. I saw one this morning that was concerned about their memory. And he was having trouble, like everybody I know, I think, having trouble remembering why he went into the kitchen and why he walked in the room, and sometimes with people's names. And I think it's important for people to understand that that's not necessarily dementia. And can you tell me a little bit about how you delineate the two?
Well, those two examples you gave are the names in particular is far and away the most common complaint that I get also for older folks is and their memory complaints is forgetting names. And then the classic, I went upstairs or I went in the kitchen to get something and I don't remember why. That's probably number 2 or 3 on the list as far as memory complaints. But you're right. Just because you have a little trouble with those things does not mean it's dementia. Depending on age, there's a certain amount of falling off that we kind of allow. After that, there's kind of a stage of cognitive issues called mild cognitive impairment, which essentially just means you're having more trouble with your memory than you should for your age, but it's not to an extent of being dementia. Those folks are important to keep an eye on, though, because that can, with some time, sort of switch into dementia. But no, just because you can't remember names definitely not that simple as being diagnosed as dementia right there.
Right. And when someone is diagnosed with dementia, I know it's important to get them on medication as quickly as possible. If you start losing brain cells, which is what we're talking about, you're not going to get them back. So it's important to protect the ones you have. Medications, it seems like we've been using the same medications for this for a very long time.
You are right. There has been nothing new for dementia, and I could probably look it up quickly, but the most new thing we have for dementia has been out for, I bet 12 or 15 years. You're right. We really have, essentially comes down to 4 medications that we use for dementia. 3 of them are very similar, and you would only use one at a time on a patient. And then there's another one, memantine, or Namenda is the brand name, that can be used in conjunction with one of those other 3. And that's about what we have in our armamentarium right now.
And I'm sure, yeah, exactly. It is sad. And I'm sure there's a great deal of research going into that. But I think if you think about the brain and how difficult it is to understand what's going up there, it makes it a little bit easier to understand why that's not something that's easy to figure out. What about, as far as meds and things, though, what about things that you hear about on the radio? I hear the advertisement for meds all the time on the radio. Help your memory, prevent memory loss. Anything to that at all?
Not that I've seen. Nothing that has been proven sufficiently, at least for me to recommend. As I'm sure you do, I got plenty of patients asking about it. I hear it on the radio or see it advertised on the internet all the time. Kind of amazing what some of them purport to do, but I have not seen any of the supplements that have had, in a reasonable study, have been proven to have any benefit. So when patients ask me about it, I caution against because of just the lack of proven efficacy, and I mean, quite simply, some of them are pretty expensive, and it's
they are.
Especially the older folks are already paying enough for medications, on enough medications and other supplements, and you throw more in the mix, and not only is it a cost issue, but then you might have to worry about interactions, and it just, as you know, the more medications people are on, the muddier the waters are.
That's very true.
I'd love for it to be the case. I tell patients all the time, boy, if somebody proves to me that eating this leaf over here or something will do the trick, I will be the first to not only recommend it, but take it myself.
Right, right.
I just don't see it yet. I wish I did.
What about alcohol as far as bringing on dementia? Is there a relationship that you've seen there?
Alcohol is a little bit of a funny one. Just with dementia, just like with other medical conditions, you always say, well, drinking in moderation helps. Drinking too much hurts, and that's probably the case for dementia. That little bit of alcohol may have some benefit actually in preserving. I've seen mixed results about that. I don't think anybody would argue though that too much alcohol, and I'm not sure I can define too much alcohol, but too much alcohol absolutely can exacerbate dementia and even cause a form of dementia, the alcohol-induced dementia that we occasionally see. Unfortunately, not too often, but it clearly can happen.
One thing I get asked a good little bit in the office is about people that have a family history of dementia, and they're concerned about that. Do you find that it runs in families? Do you find that it's hereditary?
There's likely some genetic component. I'm not sure how strong that really is. When I'm asked about it from patients, I explain that if there's family members, especially multiple family members, then just it seems to be borne out, and common sense would tell you that your risk is somewhat higher, but it's not certainly not a slam dunk like, oh gosh, mom or dad had it. The rest of us are going to get it too. That is not the case.
Good. And once somebody's diagnosed with dementia, I know the progression can happen at all kinds of different rates. There's no way to really predict most of that. But what would you tell, or what do you tell caregivers to expect, or that they need to understand about dealing with a patient that has dementia?
Well, that's a big question there. I think there's probably a lot of aspects on that one. Everybody wants to know where it's going from here. No question. That's one of the top concerns. Is all right. You just diagnosed my husband or my father with dementia. What can we expect in a year or 2 years or whatever? I dodge that question as best I can, usually from patients, because it's just so difficult. I have my own patients, some of them that clearly have dementia, but it's been terribly slow, which is a good thing, that I've been following for many years. And I'm not sure I've seen a little bit of decline over that time, but not anything terribly significant. And then I got patients, including actually, ironically, just one I saw yesterday who just really began having problems earlier this year and now is pretty well advanced. That's certainly not your usual, but you see everything in between. As far as what to tell family otherwise, I guess the most important thing is to explain to them that it will get worse, even though you can't define over what time. This is something that is going to be worse at some point. Of course, this applies to any of us, that you need to have your affairs in order, whether you've been diagnosed with dementia or not. That's always a good idea, but even probably more so if you can catch dementia early and get to the attorneys and get your power of attorneys and durable health care and all that. Then you got to worry about issues with driving and just safety, managing finances. There's so many things that come up.
And I know one thing, people a lot of times will want to, I guess, argue is the best way to put it, with a patient when they have dementia, and they will, be insistent that something hasn't happened or something has happened. And I've seen a lot of people go through the problems with that, and I think it always seems best if they just kind of go with the flow instead of trying to correct people every time. Is that a decent piece of advice for them?
Absolutely. I just wasn't this week, but last week, a patient of mine that I've been seeing for probably 5 or 6 years. See his wife as well, and almost every time they're in, we have this discussion about her getting frustrated with him over kind of the same thing. And as much as I love her, she's actually one of my favorite folks, but she just sometimes just can't let it go. Just, stirs that pot. And I told her what I tell people all the time: you got to move on. You got to distract to a different subject. You're just asking for a whole lot more frustration. It's already bad enough, but if you let that frustration level get even higher, obviously that's not good for anybody involved, patient or family. And I just remind people that it's not their loved one. It's not really the patient who's trying to be frustrating
right.
to you. They just don't know they're doing it, and sometimes people have a kind of hard time getting their head around that.
Yeah, I can imagine.
Been with them for 50 years and I've known them, and this is such a change. It's it's hard to deal with. Of course, understood.
Do you see more dementia in men or women? Is there a gender split?
It seems to me in my practice more women, and I believe the research would show that it's more women than men as well.
Makes you wonder if that has anything to do with.
I'm not sure I know why. I probably knew at some point why that might be, but off the top of my head, I don't know.
I know we could chat about why and guess about why for a long time, but the truth is we just don't know enough about this particular disease. That's the bottom line. Well, that's the bottom line, and I'm sure that's at least somewhat limiting the treatment options that we have. Talking about medications earlier, every now and then you hear about something that sounds like it might be coming out and it's promising, and I'll be damned if not, 2 months later, the studies drop because of some safety concern. Right. And right. That's just with dementia. That just seems like that's happened way too much, which is why I guess we're stuck in this rut we are right now with the very limited options. Well, that's actually something I was going to ask you about. I was going to ask you if there's something on the horizon that you anticipate coming out in the next 3 to 5 years.
I'd love to be more optimistic, but I'm not sure I've seen anything here, at least recently, that looks like it has the numbers and the momentum behind it to be available to us at any time real soon.
Right.
Which obviously is not what I'd like to say, and not like what people like to hear. But that's at least my experience.
Well, what about reducing your risk of developing dementia? And it's not really funny, but I thought I'd already asked that, but I guess I forgot. But what can we do
I can't see it between 7:30 and 8:30 tomorrow because we don't have them walk-in hours. But I could probably get you in later in the morning.
It's because you're still in the bed at 7:30 in the morning.
I don't think so.
So what can people do to help keep this from being a problem of theirs?
Well, that's another one that's mixed. I'm not sure that a month or two goes by where somebody doesn't come up with, well, there's this diet or taking anti-inflammatories or keeping your sugar under control, and not that all these things aren't necessarily good things, but all the time these things come out that seem to maybe help the risk of dementia down the road. Another one I see, and we've seen in the past, is using your mind as you get older and trying to stave off dementia.
Use it or lose it.
That's one, right? And that's one where I would love to say there's better numbers on that too. As I explain to patients, it's certainly not going to hurt to stay, obviously physically active and mentally active. But I think some of them seem to think that if they can just do enough, they'll be able to keep it away. And unfortunately, if it's going to come, it's going to come. You might delay it. You might make it slower, but not necessarily going to stop it from coming.
You mentioned anti-inflammatory.
I wish the brain was like a muscle where you can send you to the physical therapist and work on your balance and get you stronger and do that for your brain.
Exactly.
But it
yes.
just comes down to it's not that simple apparently.
And I forgot the question I was going to ask. Again, that's not.
We may need to advance that. We may need to move that appointment up.
I'll be there at 7:30 in the morning.
How long is it going to take you to get from Windward?
Not long this time of day. So, what about the memory care units? We're blessed in the area to have, and I think across the country, there's an assisted living place on every street corner, seems like, and then most of them have a memory care unit. Do you feel like society has handled the aging population and the increasing patients with dementia as well as they could? Is there something we could do better? This is not a medical question.
Sure. Yeah, that's one that I actually kind of had that discussion with a patient just this morning, or the caregiver actually, who was actually just more frustrated with her loved one staying home and having more resources there. These assisted livings with the lockdown memory care units, so we don't have to worry about patients wandering off. Fantastic. As you pointed out, you can barely turn a corner now without there being one. And there certainly seem to provide a service. But of course, a lot of people want to, for a lot of reasons, expense being one of them, because assisted living for memory cares are not cheap.
Right.
Loved ones want to keep their family member with them, not just for obviously for cost, but just because best to have a family around. And it probably is for the patient. If it weren't for safety issues, it's probably better to be in a familiar environment. Sometimes that environment's just not safe because patients wandering off stairs and family finding them, 2 miles down the road in the middle of the night.
Right.
So I'm not sure what the answer is as far as having some better in-home care that's affordable, but a lot of people would appreciate that if it was more of an option.
Well, you'll be glad to know that I remembered the other question. You were talking about anti-inflammatories and keeping sugar under control. Is there anything at all to be said for taking statins? Is there anything at all that has anything to do with dementia?
Well, that's like all. I mean, I sound like I'm saying the same thing every time, but it's just the way it is. mixed blessings. I've seen studies indicating that at least some of the statins might help to prevent dementia and help prevent some of this buildup of the proteins in the brain that occurs with Alzheimer's. But then some of the statins, in a very small number of patients, some seem to actually cause some cognitive decline. Fortunately, it seems like it probably resolves if they're off the medication. But it's just kind of interesting that it can cause some mental changes, but on the other hand, might long-term help to prevent. And I'm going to say might.
Right.
But I try not to let patients make decisions based on that, because those numbers just aren't solid enough. And the reason they're taking statins is so that they can avoid having their stroke or their heart attack.
Right.
And those things are much more likely to happen. And I hate to have patients stop the medicines for the maybe some concerns about cognition when we don't want them having that heart attack or stroke.
I gotcha. Well, that's great. And that's really all the things I had that I wanted to talk to you about, and our time's about up. But John, I believe, has some questions that people have sent in that we'd like to run by you.
A couple for you, if we can. So one is for a person who has a parent in this case, and they don't know, they think there may be a dementia issue, but they're kind of concerned about maybe broaching that with the parent. So, because they don't want to be, they want to get them taken care of, but they don't, want to alarm them. Right. So how should that, how should they approach that issue? What do you suggest?
Yeah, I'm not sure how Jim handles that one. I'm sure he's run into it too. From my standpoint, that's a concern. Patients, families all the time worried about how their loved one is gonna take the news, or is even willing to accept the news. Other than sitting down and trying to explain that you have some concern and that you think it needs to be checked out, and hey, if you see the doctor and everything's fine like you think it is, well, great, nothing's lost. But can we at least go have it looked into? I'm not sure I have a better way of handling it. But
I think
that is definitely something that can get to be a friction point. I've seen that too many times. There's a reason why sometimes I see the patients and the family separate, because it's just a subject that causes a big rift.
It is, and that's something that I'll encourage people to lay it on me and to bring them into the office and let me bring up the point that I'm seeing some things about memory that I'm concerned about, and I think we need to try some medication, do some tests, and so forth. And invariably, they're going to end up in a neurologist's office. But I think it's just
so
easier.
I get the bad guy ultimately.
Ultimately, absolutely,
yeah, of course.
Absolutely. But at the same time, I think it's something that the family needs to feel free to bring them to somewhere, and they're usually going to start with us, not going to start with you in most cases.
Right.
And so, to keep them from being the bad guy, I think it's important that they just come in and let me broach the subject. Same way with driving. I get asked, and I know you do too, I get asked all the time to tell daddy that he can't drive anymore. And usually if you bring him in and you can make a point of reflexes and so forth, you can make a good point with them and get them to not drive anymore. John? Well,
you took the words right out of my mouth. I was going to say driving is the other big bone of contention that we have to be the bad guy about.
Yeah, it's huge.
That's huge. It impacts too many people.
One other question here surrounds incidents at seemingly earlier ages. This person is citing the Pat Summitt case, the Tennessee women's basketball coach, and I guess she had early onset Alzheimer's in her 50s. Is it just coincidental, or or anecdotal? Or are we seeing more dementia and Alzheimer's cases earlier in age and stage than we used to see 10 or 20 years ago?
Well, I can speak for the last 20 years. So I'll be quick to point out Jim can can talk a little bit longer than that. I don't, in my practice, I haven't seen, I don't think, an uptick in the earlier patients. I think the patients I have in mid or late 50s with it now, I don't think that number's a whole lot different than it was 20 years ago when I started. That's my own experience. Others may see otherwise, but I'm not seeing an epidemic of 52-year-olds coming down with dementia. I'll put it that way.
Well, good. So we've been talking with Dr. Peter Futrell, a neurologist with Lakeside Neurology in Cumming, Georgia. Pete, I want to thank you for taking the time to be with us today. I really appreciate this. I think this is the kind of thing that many families are dealing with, and that might benefit them to listen to the podcast. And I appreciate you taking the time out of your day to do this with us.
Well, not a problem. I'm sorry I couldn't join you in the studio there, but happy to help, of course.
Good to have you anyway. Thanks very much. So for now, this is To Your Health.